Hi everyone, today we will discuss about the periodontal pocket. Periodontal pocket, as you all know, it is just the pathological deepening of the gingival sulcus. Usually the gingival sulcus would be intact, but in the case of pocket, it gets deepened more. Then how we will calculate the pocket depth? Pocket depth we will calculate by measuring the distance between the gingival margin to the base of the pocket. So gingival margin is this. This is the gingival margin and the base of pocket is here. So we have to calculate the distance between the gingival margin and the base of the pocket. Let's see the classification. First, we will see the classification based on the relation between the base of the pocket and the alveolar bone. So this is the alveolar bone and here is the base of the pocket. So based on this relation, it is divided into supra-bony pocket and infra-bony pocket. So what do you mean by supra-bony pocket? Supra-bony pocket means the base of the pocket is coronal to the level of the alveolar bone. So alveolar bone is here. So the base of the pocket is coronal to the alveolar bone. But in the case of infra-bony pocket, the base of the pocket is here, but the crest of the alveolar bone is here. So now the crest of the alveolar bone is above the base of the pocket. So that is the case of infra-bony pocket. And moreover, the bone loss usually would be vertical here, but in the case of supra-bony pocket, the pattern of destruction of the underlying bone is horizontal. So this is one type of classification, and other is depending on the morphology. It is divided into pseudo pocket, true, and combination pocket. Pseudo pocket means is just the gingival overgrowth. So nothing has happened here. The gingiva has grown more and no attachment loss because this everything is intact. The attachment is intact and no bone loss, nothing. Only the gingival overgrowth can be seen. So this is the pseudo pocket. Whereas in the case of true pocket, we can see definitely the attachment loss. That means the apical shift of the junctional epithelium. Actually, the junctional epithelium should be here. Whereas in the case of true pocket, we can see the apical shift of the apical migration of the junctional epithelium. So that means we can say that attachment loss can be seen. Plus the bone loss also can be seen here. See, this is the actual, sorry. So this is the actual, bone. Usually this is the normal bone, but in the case of pocket, the bone is like this. So this much of bone loss happened. In the combination case, we can see both gingival overgrowth can be seen and the attachment loss. So this is the classification based on the morphology. Then based on the surface involved, it is again divided into simple, compound, and complex. This is, can you see here, only one surface is affected, that is called as a simple pocket, whereas in the case of compound pocket, we can see two or more surface. So this is the complex pocket. And depending on the disease activity, it is divided into active and inactive, that I will explain later. Then what is the pathogenesis of the pocket? How the pocket is formed? Usually the normal case of inflammation, that I uploaded a video based on that. This is a normal case of inflammation, but we have to see what is going to happen in the case of pocket. Normal case, what we can see is when a bacteria enter inside, the immediate response is by the mast cells. These mast cells, they release the certain chemicals such as histamine, leukotriene, and prostaglandin. And these receptors, they release, these mast cells release these chemicals into the plasma, and these receptors, these chemicals, they act on the receptors on the blood vessels. See, this is a blood vessel. Certain receptors are there on the blood vessels, and these chemicals, when they act on these receptors, which activate the p-selectin. and this p-selectin has the binding area. So the binding of this p-selectin with the p-selectin on the neutrophils. So here we can see the neutrophils are flowing inside the blood vessels. So this blood vessels, the neutrophil has a p-selectin, then this bacteria has also the activated this p-selectin. So these two get bind together, and that causes margination. So this is known as margination, and then diapedesis happen because they start to roll on, and that is known as diapedesis, and they release cytokines, and these neutrophils and lymphocytes, they release into the muscles from the blood vessels, and they act and proceed the inflammation. So this is a normal cascade of inflammation. But what is going to happen in the case of pocket? So this, in the case of pocket, what is going to happen is that if the plaque had virulent bacteria and intense inflammation, tissue breakdown happen. So a tissue breakdown occur in the connective tissue and also in the epithelium. Connective tissue, we have fibroblast. So these fibroblasts, PMNS and macrophages, they release MMP, that is the matrix metalloprotein. They are certain type of collagenase. These collagenase helps in the destruction of the collagen, and due to the fibroblast itself, they directly act on the collagen and collagen destruction occur. So this is happening in the connective tissue. Whereas in the case of epithelium, this inflammatory cytokines produced, they break the protein which forms the intercellular connecting unit. This is the, if this is one cell, this is another cell, they connected together with the help of desmosomes and hemidesmosomes. So these cytokines, they break this protein. So because of the epithelial attachment breakdown, apical shift of the junctional epithelium occur. So this apical shift of the junctional epithelium causes the deepening of the sulcus, and that leads to the pocket. Along with that, some small ulceration can occur on the lateral wall of the pocket. This is the lateral wall of the pocket, and due to these activities, some ulcerations can occur on the lateral wall of the pocket. So what is going to happen is that these microorganisms, they enter inside the connective tissue. This is the connective tissue. So because of the ulceration, these microorganisms, they enter inside the connective tissue. So now the neutrophil cannot migrate into the gingival sulcus and attack bacteria there. So it will phagocyte the bacteria inside the connective tissue itself. So in the same line, if bacteria still virulent and start attacking other cell, then the tissue destruction occur. So the phagocytosis is going to happen inside the connective tissue itself. See, you can see the cell and this phagocyte this bacteria, and because of this kind of processes happening inside the connective tissue, the surrounding tissue destruction can occur. So at this stage, if host responds to the bacteria attack by activation of various other mechanisms like lymphocytes, macrophages and monocytes, then host able to arrest the disease process. In that case, there is a formation of inactive pocket. That's why I told there are two types of pockets are there, active and inactive. So that kind of pockets are happening due to these process. And if the host is not able to arrest the disease process and the destruction by bacteria and host mediated enzymes are still occurring, then it is known as active pocket. Sorry. Now we will see about the pocket content. There are two types of contents are there, foreign materials and host material. Foreign materials are plaque, calculus and microorganisms that may be living or dead. Host is the GCF, that is gingival crevicular fluid. Usually this GCF quantity is less in normal sulcus, but in the case of periodontal pocket, this GCF quantity can increase. Then salivary mucins, desquamation of epithelial cells, leukocytes, fibrins, these all can be seen. Next we will see about the surfaces. There are two surfaces are there. One is the hard tissue component or tooth surface area. The other is a soft tissue component. Soft tissue component in the case of pocket we will call as the lateral wall of the pocket. First, we will see the hard tissue component. So, this is divided into different zones. The first zone is covered by calculus. So this zone is covered by calculus, and the zone 2 is a zone of attached block. So these two are associated with block. And zone 3 is the zone of unattached block, because can you see the blank area here? So that is a zone of unattached block. Here it is not attached, this block is not attached to the tooth surface. Instead, it is associated with the soft tissue. So that is the case of zone of unattached block. And next zone is a zone of junctional epithelium. Then the other zone 5 is a zone of semi-destructed connective tissue fibers. And below zone 5 we have the healthy connective tissue fiber, which is absolutely normal. So these zone of unattached block set 3, 4 and 5, these three are block free areas. The first two are associated with block. Next, we will see about the soft tissue component or lateral wall of pocket. In healthy patient, we will call this area as the sulcular epithelium, whereas in the case of pocket, we call as the lateral wall of pocket. Then there is a constant change in the pocket wall is happening because of the inflammation between the host and the bacteria. First area is the area of relative quiescence. This area is not affected and seen as just a flat area with some small depression, and here the normal shedding of epithelial cells are occurring. The second area is the area of bacterial accumulation. Here, the abundant debris and bacterial accumulation is happening. Microorganisms like cocci, rods, filamentous, spirochetes, these kind of microorganisms would be there in this area, and they try and penetrate inside the epithelium through intercellular epithelial gaps. And next area is the emergence of leukocytes. So now the host is trying to control the disease activity by producing certain leukocytes, this type of cells. And next area is the leukocyte bacteria interaction. Now this war is going to happen, and this leukocyte and bacteria, they interact each other. And next area is the intense epithelial desquamation. So this area associated with lot of destruction. So lot of epithelial cells undergo desquamation and shedding. Next is the area of ulceration. So here I have discussed before the underlying connective tissue exposed. The next is the area of hemorrhage. Then we will see the clinical features and histopathological features of the pocket. We will see the sign and symptoms here. First is the clinical feature is the gingival wall of the pocket. We can see some various degrees of bluish red discoloration, flaccidity, a smooth and shiny surface, and pitting on fissure. These all can be seen. And less frequently we can see some pink firm gingival wall, and if by the gently probing the soft tissue wall of the pocket, we can see bleeding, then painful while probing, and many cases like pus with digital pressure. These all are the signs of the pocket. Then what would be the symptoms of the periodontal pocket? That is a localized pain, sensation of pressure after eating, which gradually diminishes. In some specific area, they may feel some foul taste and feeling of itchiness and radiating pain. Then thermal sensitivity would be there, and feeling suck materials in interproximal space, and toothache in the absence of caries. Then what we can do as a treatment of this pocket? So we can do the pocket reduction surgeries. So the aim of these surgeries is reducing the probing pocket depth in patients with periodontitis. If in the case of suprabony pockets, we will treat by the resective procedures like gingivectomy, osseous surgery and all. Infrabony pockets will treat by the regenerative approaches. Then we will see the relationship of the attachment loss and the bone loss to the pocket. This is a periodontal pocket depth. Usually we measure the periodontal pocket depth from the marginal gingiva to the base of the pocket. If this is the gingival margin and if this is the base of the pocket, we measure the pocket depth from the marginal gingiva to the base of the pocket. So you can see if we insert a probe inside the pocket, it has to measure from the gingival margin to the base of the pocket, whereas the clinical attachment loss we measure from the CEJ. The CEJ is a fixed point, that there is no change in that, so we have to measure from the CEJ to the base of the pocket. So that is the difference between PPD and CAL. If the marginal gingiva is at the CEJ, the pocket depth and attachment loss would be same. But if there is any gingival recession like this, then how we will measure CAL is that it has to measure from CEJ to the base of the pocket. Sorry. So see if the pocket depth is from the gingival margin to the base of the pocket, that is we can, let's say it's 5 mm, and if gingival recession is 1 mm, then we will add 5 mm plus 1 mm to get the clinical attachment loss. Whereas in the case of gingival overgrowth, the gingiva is here. So now the probing depth we will measure from the gingival margin to the periodontal pocket. Usually that we have to measure from this area to this area. So now the pocket depth is 5 mm. So sorry, the pocket depth is 5 mm now, and gingival overgrowth may be 2 mm. So now we need to subtract this pocket depth from the gingival overgrowth to get the clinical attachment loss. So this is all about a pocket depth, periodontal pocket. Now we will see some of the questions. So first is, when using the periodontal probe to measure pocket depth, the measurement is taken from that is the thing I told you just now, that it has to measure from the base of the pocket to the crest of the gingiva. The next question, initial therapy for periodontal pocket that are deeper than 5 mm must include supragingival scaling and what? So this is the initial therapy, because it is not about the surgery or anything. What we need to treat the pocket first. So initial therapy is just to instruct, motivate, that kind of treatment we have to give. So now the depth is more than 5 mm. So we need to do the supragingival scaling and root planing is the answer. Antibiotics definitely we have to give, but that is not the initial therapy. Then polishing is not the answer, irrigation is not the answer, so root planing is the answer. Next is, in an infrabony pocket, the tip of the periodontal probe is located. So now infrabony pocket means the base of the pocket is here. So base of the pocket is here and the crest of the alveolar bone is here. So the tip of the periodontal probe will go apical to the level of the alveolar crest. Then this I discussed just now, so I'm not going to answer that. Next is, in a 51-year-old patient with well-controlled type 2 diabetes and generalized moderate chronic periodontitis, which of the following is the most appropriate management of periodontal pocket? Appropriate management definitely would be scaling and root planing, not the other. These all are false. That eliminating periodontal pockets by gingivectomy results in so this I will discuss later. This is not included in this chapter. Then when the gingival margin is at the level of CJ, the attachment loss is equal to pocket depth, that I discussed just now. Then following periodontal flap therapy, the most common cause of recurrence of pockets is not the systemic disease or traumatic occlusion or failure of splint or anything like that. It is mainly because of the poor oral hygiene. So that we have to maintain the oral hygiene even after the periodontal flap surgery. Then the gingival pocket or pseudo pocket is characterized by loss of attachment. No, because loss of attachment and loss of alveolar bone cannot be seen in the case of pseudo pocket. Deepening the probing depth is the answer. So next is detection of periodontal pocket is done by probing. A characteristic of periodontal pocket is gingival edema. No, in the case of periodontal pocket, definitely we can see the alveolar bone loss. Then following periodontal debridement, reduction in pocket depth is primarily due to decrease the inflammation. So this primarily this reduction of pocket depth is due to the decreased inflammation. These all are there, but these all are the later process. Initially, decreased inflammation is the answer. Then in an infrabony pocket, the epithelial attachment is located that I discussed. It is apical to the alveolar bone crest. Then which of the following is the most likely cause of periodontal pocket formation following crown preparation? So that is the invasion of the biological width. If we do anything wrong in the biological width, that definitely affect the prognosis. The absence of adequate drainage in a periodontal pocket may result in abscess. So if we cannot do a proper drainage in the periodontal pocket, that can lead to abscess. That I will explain now. So what is periodontal abscess? So it's a localized purulent inflammation in the periodontal tissue. So it can occur due to several reasons. One of the reason is the formation of abscess results when drainage into the pocket space is impaired. If we do anything like that, the periodontal abscess can occur. It is of two types, acute and chronic. Acute means rapid destruction of the periodontal regions due to food impaction, overhanging margins, calculus, or toothbrush bristle, etc. And the chronic periodontal abscess is due to the sinus tract, usually asymptomatic, no pain or dull pain, and slight tooth elevation or intermittent exudation can be seen. So this is all about the periodontal pocket. I have discussed some of the questions. If you have any doubts or anything, you can comment me in the comment section. Thank you.